Hey everyone, it's your Professor Heather Vernillo, and I am here to give you week 2. I'm going to do an introduction to psychiatric nursing. I am a family nurse practitioner, but I went back and did a postmaster's in psychiatric mental health nursing. So I am working in both realms of family practice and psychiatry, and I'm going to give you a background on why that happened. In my family practice setting for the past 10 years, I had noticed that a lot of these simple tasks that I'm doing, sinus infection, strep throat, cough, ache, UTI, turn almost into mental health lessons, especially during the COVID shutdowns and the pandemic and all the things that went with the social isolation. And I will apologize for my birds because they like to talk during my lectures. Okay, so I decided to then basically I wanted to get paid for the mental health I was providing in primary care because those codes cost more or get paid more. So long story short, I went back and got my mental health nursing. So I am here today to talk about pretty much an introduction to psychiatric nursing. So we're going to go kind of over like the nurse's role and different therapies, little condensed version, just to kind of supplement the things that you're learning about in your book. All right, so like all people, patients, and I never know where the camera is. So if I'm like looking the wrong direction, like I'm just really old. So technology is not my friend. So like all people, patients with psychiatric conditions, they're in all medical settings. They use medical clinics for wellness and for injuries. They're in hospitalizations. They're in surgery. They're everywhere. Okay. Mental health knows no race, no gender, no age, no mental illness or medical illness. So any patient in any medical setting that you encounter, you're going to encounter a patient with mental health issues. They could be distressed or confused. Being in a hospital itself is very scary. So someone who had an underlying anxiety disorder, this might be where it presents. So anxiety, depression, confusion, all commonly seen throughout the whole general population. And with the increase in longevity of human life, we're seeing a lot more dementia. Right? So you don't need to work in a psychiatric unit to encounter patients who have psychiatric conditions. Okay, I worked in labor and delivery for a part of my career, and they had psychiatric conditions, bipolar, schizophrenics, very depressed patients, anxiety patients, OCD patients. They are able to give birth. They are able to get pregnant. And then their partners could have these issues too, which only compounds, things in the delivery room. So don't think that you have to work in psych to encounter psych. If ER nursing is your passion, learn the tides and learn the moon because it's a thing. Okay. So to work effectively with any patient, it's essential to consider not only their physical concerns, right, but their psychological issues that may or may not be present. They may not even report them to you. There is a huge stigma with mental health, and patients don't want to come out like if they have, they broke their toe, they don't kind of want to come out and say, yeah, I have bipolar, manic depression. Like not everyone wants to come out and like say these things. It's not you'll get looked at differently than if you say, oh, hey, I'm a diabetic. But in reality, they're both medical illnesses, right? But we do have that stigma. So according to the Department of Health and Human Services, mental health and substance use disorders spending is projected to increase from 171 billion to about 280 billion. We've already surpassed that because that was the number for 2020. Worldwide pandemic, of course, added some billions onto that. So understanding of psychiatric illnesses has grown significantly over the past decade, and the link between physical and mental health is actually becoming more understood. And we're actually starting to slowly lose that stigma, which is great. So additionally, the care for patients with psychiatric conditions has evolved from inpatient hospitalization, right? Like back in the 50s, if you were like even a little hint of a psychiatric issue, they institutionalized you And now we're actually doing community-based outpatient programs, which is really great. Advocacy programs, assertive community treatment programs, assisted outpatient treatment programs. We all provide follow-up care. We provide monitoring with patients with psychiatric conditions. Our schizophrenics, we have these long-acting injectable clinics where they can come, and they either come every 1 month, 3 month, or 6 month, depending on which one they're on. And they don't have to remember to take a pill. So they're getting this long-acting injectable, and they're the reproductive members of society, and they're holding jobs, and they're doing the things that they need to do because there is a community program for them, and there's somewhere for them to go and have that accountability. So programs are available. We provide support, education, substance use programs, especially after the pandemic. Substance use skyrocketed. Tampa Bay was not immune to it. We have a lot of issues here. I'm not sure where my students are, but I'm in the Tampa Bay area. We have bereavement support. We have victims of violence groups. We have increase of homeless population. Homeless population tends to have a little bit more of mental health issues that may, which one came, first, the horse or the cart that put them in that situation. But so we're actually doing a lot of outreach into the shelters as well. Psychiatric concerns are reported now way better than they were in the past. And I don't know if I want to blame TikTok or congratulate TikTok or whatever social media program is reaching out to the younger generation to say it's okay to not be okay, and coming out and saying, hey, I think I need help. I'm from the Gen X generation, and if you've ever watched any videos on social media making fun of Gen X, those tend to be very accurate. We're very stoic. We tend to eat our emotions. And my age group has one of the highest substance, use issues because of that. So I'm very hopeful for this younger generation. We have seen a number of tragedies reported in the media. We got shootings in schools, shootings in universities, people driving their cars through parades of people. It's like sadness almost every day, right? So are these people who are committing these crimes, are they untreated, or were they poorly monitored with psychiatric conditions? So they remind us of the seriousness of having an untreated illness. It takes a very certain mind state to walk into a school and kill people. All right, so looking at New York Times bestsellers, or looking just at if you go on Amazon Kindle and just kind of look up suggested texts, there's so many books on coping and mindfulness that are #1 bestsellers because people know that they're not okay and they're looking for help. We have advertisements on TV for antidepressant medication. There's always something new coming out. So that tends to open up the conversation when the person comes into primary care of, hey, I saw this, video commercial on YouTube for Trintellix, and it said that it's really great for this type of depression, and I think I might have that. Sometimes, it becomes a beast of they think they have things that they don't have. TikTok again. A lot of people think they have ADHD that do not. They usually have really bad anxiety that keep them from being able to focus. But okay, not for this introductory course to psych nursing, but something we can talk about in future weeks. So our understanding of neurobiology is improving, right? So this growth in knowledge, awareness of physiological foundations. We have genetic testing now that even can genetically test which SSRIs or which antipsychotics our body actually processes better, can help us pick better treatments based actually on individual DNA, which is amazing. And so we're increasing our knowledge, we're increasing diagnosis as a people. So when they say, oh, there's a lot more people with mental illness, there really isn't. We have the same number of people, we just actually are diagnosing them better now. They're not hiding behind a stigma. They're not sitting on their couch alone and isolated. They're actually out getting help and getting a diagnosis. So that is a part of why the numbers have increased. We're also, as a people, the coping skills are not being taught. Household dynamics have changed. The economy is causing mothers and fathers to have to both go out to work and for daycares to raise children. So it's all the word I cannot pronounce, cumulative effect, basically. So our education as nurses, particularly in psychiatry, is teaching us to really look holistically at our patients, right? We know through research and nursing practice experience that emotional stability and resiliency improves outcomes and recovery for both medical and psychiatric. Doesn't matter. They're both the same. Psychiatric consults are now ordered more readily. Healthcare professionals are observing and recognizing symptoms early, and we're delivering the care that these patients need. We know that there is a link between stress and disease. Hans Saley might be in your textbook, talks about the link between environmental and biological response, and that emotional and physical stress can actually cause a pattern, and left untreated actually can lead to infection and illness, and it can even lead to death. So they called this thing a general adaptation syndrome, and identified it into 3 stages. There's the alarm reaction where your body's recognizing it. There's the resistance phase, and then when the body finally gives up and goes into exhaustion. So alarm, it's any physical or mental trauma trigger. It's giving an immediate biological response to counter the stress. Think about like the fight or flight in the sympathetic nervous system that you learned about during like anatomy and physiology. So these responses, they depress the immune system, they lower the resistance, and they make you more susceptible to infection and disease. So unless the stress is, unless it's very, very severe, the stress, it usually doesn't stay prolonged and the person will recover. Now, resistance begins when the body starts to adapt to this prolonged stress. The immune system will shift into high gear to meet the increased demands. And at this point, the person becomes more resistant actually to the illness. However, the perception of the threat will linger. If you think about anxiety, it's being worried about something that hasn't happened yet, whereas depression, you're worrying about things that happened in the past. So you're constantly in this state of like intrusive thoughts. So as this threat lingers, we try to reach a physiological equilibrium. The body, it stays aroused. It stays in that hypersympathetic state. And that places stress on our organs and on our body systems. Because adaptation appears to work initially, the person in resistance stage may become complacent and assume that everything is fine, that they don't need to take any steps to reduce their stress because, they're handling things. But then chronic stress will kick in, adaptive mechanisms eventually just wear down, and the body no longer can meet the demands of that stress. So your immunity and your resistance will decline. Illness is likely to set in. The point of exhaustion, it's and it differs with everybody. My point of bodily exhaustion might be completely different than a close friend of mine or even a sibling. Because we all have individual life experiences that change things. So this particular theorist worked to lay that foundation of using relaxation techniques to interrupt the stress response and reduce susceptibility to illness and disease. And these are things that we bring forward into the hospital. You'll notice they have a lot more programs now where they walk around with like a cart full of maybe comfort foods and books and magazines. A lot of places have different hypoallergenic dogs that come around, or other, animals that are used for emotional, support. Because who doesn't want to play with a little puppy, So we're kind of learning to bring those comforts and reduce that stress, because being in the hospital is a very stressful time. And this other research was also applied to post-traumatic stress with the military. So the VA is actually doing a lot of work right now with it. Psychological or psychiatric conditions affect all socioeconomic populations, all ages, all genders. Right, that was in your reading. And also, if you watch the YouTube video on social determinants, it talked about socioeconomic populations. According to the NIH, National Institute of Health, suicide was the second leading cause of death for individuals between the ages of about 10 and 34. So young children and young adults, they kind of fall in that realm. That was pre-pandemic. Suicide is still up there, but now we got this coexisting substance use disorder. And the problem is that a lot of people are ODing and it's getting marked as either suicide or an OD, and it was like vice versa. So you really have to look at both of those numbers because they're like the number 2 and the number 3 killer. Number 1 being violence. Unfortunately, there are some areas of the country where children are constantly being the victims of violence, not sometimes directly toward them, but they're in like the crossfire. So unfortunately, and accidents, don't forget, they're dark, especially some children are a lot more adventurous. So accidents do cause a lot of death too. But we're looking at things that we could probably control a little bit better, and substance use and suicide are things that are very high in that population. Alcohol, substance misuse, dependence, all increasing. We really need to stay on top of this and monitor our patients who are coming in. We have programs now. Florida belongs also to that PH, whatever, I can't even pronounce all the letters. We call it E-Force, but it's basically we can look for people who doctor shop and who fill scripts at multiple pharmacies across multiple states. Not every state belongs to it, but enough of them have joined that we can just simply press a button and see all the prescriptions that were written and where you filled them at. And it gives a risk score because this is how people try to circumvent the system. So biggest thing I want you to take away from the beginnings of this course is that there is a manual called the DSM, put out by the APA, which is the American Psychiatric Association. The DSM-5 is our current manual, and it lists every disorder possible that falls under our realm and its criteria. So understanding the DSM-5 will really help you in this course. Diagnostic criteria and codes, that's more for like the billing thing, but you'll notice if you work, you'll start seeing the same codes like over and over again. F33.1 is, depression, moderate depression. F41.1 is generalized anxiety disorder. So you'll see those. Any of the F32s are your bipolars. And then they break them down. Bipolar currently manic, bipolar currently depressed, bipolar currently moderately depressed, bipolar with psychotic symptoms. Like they're even coded down even to the like minute level of things so that we can make sure the person's getting the care that they need. Our hope is that this DSM-5 will be useful for not only psychiatry, but it being used by primary care physicians to assist patients. And I really think that's probably about all I have for your intro to psychiatry. The role of the psychiatric nurse is actually recognized by the ANA, the American Nurses Association. It's a specialized area of nursing practice, and it might be something that after this course, you might think like, hey, I think I want to do some psych nursing. It's a really great field. Depending on where you live, there's usually, like in my area, the psych facilities are Mies, Dunedin. We have a small unit in Wharton Plant. We have Town and Country. Town and Country is probably a really good one. But if you really want to get into the nitty gritty of psych nursing and really get in the trenches and learn a lot, is getting a job at the VA. James Haley Hospital is our main psychiatric facility in the Tampa Bay area. You will get into like a nurse residency program, and it absolutely fascinating. That's if psych is your thing. It's not everybody's thing. Psychiatric nursing incorporates the science of nursing and clinical assessment skills, but with the art of like that therapeutic use of self. You're establishing rapport, you're establishing professional therapeutic relationship, and you have to have empathy for your patients. You have to be able to not absorb a lot of the things that they're telling you, especially when you're learning about like a lot of childhood traumas and sexual traumas, but you need to be able to have that empathy so that you can build that relationship, because nobody wants to talk to somebody who just sits there with their hands like this and just stares at you, because that's very cold. So you have to know your own personality of whether or not you could handle being in psychiatric nursing. We still perform all the traditional roles of nurses. We administer prescribed meds. We monitor the efficacy of those treatments, and we're always educating our patients. Always, everything you do, you're educating patients, right? But psychiatric nurses, they engage patients and the families and in therapeutic models, and they understand how to improve illness and improve function. And psychiatric nursing is in every healthcare setting. We have inpatient, outpatient, community health. We have mental health clinics. We have visiting nurse services. I apparently need more coffee because I cannot pronounce anything today. So the practice is diverse, right? So you don't have to feel like you're stuck in acute care in the hospital. There's so many different things. We have so many substance use disorder. If you decide to work for like the county health department, there's a lot of work that a registered nurse can do in psych. And to work with patients with mental health conditions, the psychiatric nurse to me is the person that brings the calm to the storm, right? Because the doctor or the psych nurse practitioner, they're just there for a small little snippet, little exam, a little conversation, a little mini mental health status. They put their orders in, they go away. And you're in the acute care setting, you're with that patient, for the next like 11 and a half hours of your shift. So they're going to bring challenges. These patients are complicated. They're very distinct and they're very individualized. No two patients with the same mental health disorder will present the same way. Everybody is different. All right, so we need to establish a therapeutic relationship, and that's kind of when the healing will occur. I think that the psychiatric nurse is very versatile, and they're much needed. So think about it. If you want to effectively work as a psychiatric nurse, you really need to become aware of your own biases and beliefs. And everybody has biases. So if you say, I have no bias, you do. So you need to explore those. You need to take an inventory of what drives you to make decisions. And that allows you to fully understand yourself before you can understand others. So although it is impossible to completely separate our core beliefs, but we can't. You are who you are. You were brought up and you were raised with your basically who you are. So it's essential that you're able just to set aside those bias and accept the fact that our patients probably feel differently than we do about things. And they ultimately will make different decisions than you would if you were placed in the same situation. So giving patients the autonomy to which they're entitled reinforces your duty as a nurse to provide that accurate information. And if they choose to decline it, they choose to decline it. And you have to be able to walk away with that, knowing even if they are going to hurt themselves, that you still did everything that you could do. And whether or not they choose, and it's really no different than the diabetic who's choosing to eat a donut. Like, we know they need to take their insulin. We know that they need to eat less carbs. We know that they need to eat less processed foods, but we still see them do it. So it's really no different for mental health care. And I think that is about all I really have. Make sure you review your scope of practice. The Nurse Practice Act, that applies for anything when it comes to NCLEX. You should always know your professional practice standards and things that are needed for certifications, and the particular state that you're going to choose to work in, that that state's regulations and scope of Nurse Practice Act, because it may be different state to state. Then your Nurse Practice Act sets the minimum standards for entry into practice. So the NCLEX you take is the same NCLEX someone in Idaho was taking. But if you're working in the state of Florida, we do have different like delegation laws in some of the other states. And with that, I bid you adieu. You have a great week too. Make sure you read all your lectures. Make sure you watch the video on the concept map. Email me with any questions, and make sure you do your quizzes on time. This is an asynchronous course, and a lot of the onus is on yourself to do a lot of the self-teaching with the reading, but I want to be here to reinforce you. So if you have questions, send them to me. Everybody has a different schedule. Like not one person was able to meet for a Zoom live session at the same time. So I'm thinking that that's probably just not going to be the best idea. I mean, we could always do them and I could record one and the people who couldn't make it can just watch the replay. Just let me know if that is something that you'd like to do. All right. Anyway, have a great week. Stay safe.